Hello, my name is Kevin Fernando and I'm a GP partner at North Berwick Health Centre near Edinburgh and also Education Director for GP Notebook Education. Today I'm going to talk about the VERTIS CV trial, the cardiovascular safety trial for ertugliflozin, one of the SGLT2 inhibitors. Now many of you will be aware, since concerns were highlighted about rosiglitazone, one of the thiazolidine-dione anti-diabetic drugs during 2007, it was made mandatory both in the US and also Europe for all new diabetes drugs to prove their cardiovascular safety compared to placebo. Now we've had a range of these cardiovascular safety trials published over the years, and specifically 3 around SGLT2 inhibitors, namely EMPA-REG Outcome exploring the cardiovascular safety of empagliflozin, the CANVAS trial program exploring the cardiovascular safety of canagliflozin, and DECLARE-TIMI exploring the cardiovascular safety of dapagliflozin. And indeed, these 3 trials did indeed demonstrate the cardiovascular safety of the respective drugs compared to placebo, but incredibly, they also demonstrated significant benefits in terms of adverse cardiovascular and renal outcomes. So these studies have been some of the biggest studies to have been published in type 2 diabetes for many, many years, and have had a big impact on changing clinical guidance, changing practice, and helping improve the lives of people living with type 2 diabetes. So of course everyone is eagerly awaiting the results of VERTIS CV, the ertugliflozin cardiovascular safety trial, with many of course predicting it would mirror the results of these other SGLT2 inhibitor trials I mentioned. So VERTIS CV was a large, high-quality, well-conducted study over 8,000 individuals living with type 2 diabetes and importantly with established atherosclerotic cardiovascular disease. That is to say, this was a secondary prevention trial. And individuals were followed up for around about 3 years. Now, the primary endpoint of the VERTIS CV trial was the non-inferiority of ertugliflozin compared to placebo for MACE, major adverse cardiovascular events, a composite of cardiovascular death, non-fatal MI, and non-fatal stroke. Secondary endpoints of VERTIS CV included superiority for cardiovascular death, hospitalization for heart failure, and adverse renal outcomes. So, what did VERTIS CV find? Well, VERTIS CV did achieve its primary endpoint. So it did demonstrate that ertugliflozin was indeed non-inferior to placebo for MACE, but it didn't actually achieve its secondary endpoints. Unlike those other SGLT2 trials I mentioned, it did not demonstrate any beneficial effects in terms of cardiovascular death, hospitalization for heart failure, and benefits in terms of adverse renal outcomes. Overall, there was observed a 30% reduction in hospitalization for heart failure, but this was not a statistically significant result. From a primary care perspective, I think what was probably most helpful was the reassuring safety profile of ertugliflozin. As predicted, we saw increased rates of mycotic genital infections, thrush-like infections in women, balanitis-like infections in men, and also an increased rate of UTIs. We've seen this before in other trials and in our day-to-day clinical practice, and this is to be expected as a result of the mode of action of an SGLT2 inhibitor. But also reassuringly, there was no signal for amputations, for DKA, diabetic ketoacidosis, for fracture, or for Fournier's gangrene. I think these are very helpful messages for primary care, as these have either been highlighted in past studies or we have had MHRA alerts about them. That said, we mustn't be complacent. The MHRA does specifically warn us to be aware of the rare complication of euglycemic diabetic ketoacidosis with all SGLT2 inhibitors. Rare, 1 in 1,000 to 1 in 10,000, and the benefits of this class of drug do outweigh the risks for the majority of people living with type 2 diabetes. VERTIS CV also demonstrated numerically fewer acute kidney injury events. This has also been seen in other SGLT2 trials and really adds to the evolving evidence base that SGLT2 inhibitors probably have a protective role in terms of acute kidney injury. So really the question on the tips of everyone's tongues after publication of VERTIS CV: can we say the benefits of SGLT2 inhibitors are a class effect? Well, in my opinion, I think the benefits are a class effect. Yes, we've seen some slightly different results with VERTIS CV, but I don't feel that there's really any plausible physiological or pharmacological reason why there should be differing cardiovascular and renal benefits within the SGLT2 inhibitor class. That said, we should continue to practice evidence-informed yet person-centered medicine. So currently, for individuals living with type 2 diabetes and renal disease, the evidence best supports canagliflozin. For those individuals living with type 2 diabetes and heart failure, the evidence best supports dapagliflozin. And for those living with type 2 diabetes and atherosclerotic cardiovascular disease, the evidence best supports empagliflozin, particularly because it's the only drug that has demonstrated within the class a significant improvement in cardiovascular mortality. So as always, one size does not fit all. We should continue to individualize our choices of therapies after metformin according to that person sat in front of us, and not just think of the glycemia, but look at significant comorbidities as well. So thank you for listening, and I hope you found this video helpful.